So thank you everyone for attending this scientific lecture, and thank you to PPS Norlu for inviting me to talk about bone tumors. Okay, so moving on. Whoops. Oh, there you go. So bone tumors in children, only half of bone tumors in children are malignant and the other half non-neoplastic. Nothing beats good history. So when we take the history, we should consider the age, the presence and absence of pain, the duration of pain. Patients may tell it's a very distinct kind of pain. Also, we should ask for history of trauma, how long the symptoms have lasted, whether there is swelling or an effusion adjacent to the lesion, or swelling related to a soft tissue mass. Is it a painful swelling or a asymptomatic swelling? And lastly, we should also ask for constitutional signs and symptoms. It is important to do a thorough physical examination. So we evaluate for tenderness, swelling, and associated soft tissue mass, and any kind of deformity that would suggest the lesion has been there for a long time, and check for the range of motion. Addition to history and physical examination, another piece of information that can narrow down the diagnosis significantly is the radiograph. So on the radiograph, consider the location, borders of the lesion. Are they well defined? Is there sclerosis around the border? Look at the number of lesions. Does the patient have multiple lesions in different bones? Look at the type of destruction. Is it uniform or moth-eaten? If moth-eaten, it suggests a malignant process. And also, we should consider the presence and absence of a periosteal reaction. So shown here are different types of your periosteal reactions. In medical school, we learned about sunburst or hair on end pattern suggestive of your osteosarcoma. And a Codman's triangle as shown here. When you see a Codman's triangle, it is a tumor pushing out onto the periosteum, suggesting an aggressive process. Here, this picture shows a lamellar or onion skinning of the periosteum, which we may see in cases of osteosarcoma, Langerhans cell histiocytosis, or even osteomyelitis. Also, next is you should look at the type of the matrix. As you can see here, we see a cottony or cloud-like matrix seen in osteosarcoma cases. And lastly, we should check for the extent of soft tissue involvement. Moving on to the main topic of this lecture, primary malignant bone tumors. So bone sarcomas are the 6th most common malignant neoplasm in children, and the most common tumor types we see osteosarcoma and your Ewing sarcoma family of tumors, or your ESFT. In this pie graph, it shows that about 60% of your bone tumors in children are osteosarcoma, roughly 30 to 40% are your ESFT, and less than 10% are other tumors. Okay, so osteosarcoma is the most common primary malignant tumors of the bone that are characterized by the production of osteoid or your immature bone by the malignant cells. It accounts approximately 3% of all cancers in children. The estimated annual incidence in the US is 3.9 cases per 1 million population, while in low to middle income country like the Philippines, there is a lack of population-based cancer registries, limiting our understanding of this bone malignancy. So locally in the Philippine General Hospital, where we see around 300 to 350 new cancers annually, osteosarcoma is the 5th most common solid tumor. And in a retrospective research done during this period, there were about 100 new patients seen. Okay, So for osteosarcoma, there is a bimodal age of distribution, with incidence peaking in early adolescence and in adults over age of 65. So most osteosarcomas occur during the first 2 decades of life that appears to coincide with adolescent growth spurt. There is a unclear relationship between rapid bone growth and osteosarcoma. It is speculated that the bone tumor arise from aberration of the normal tumor. Uh, it is speculated that the bone tumor arises from aberration of the normal process of bone growth and remodeling at time when rapidly proliferating cells are particularly susceptible to oncogenic agents or mitotic errors or other events leading to a neoplastic transformation. Also, patients with this bone tumor are taller than their counterparts without the disease, and it develops earlier in females as it coincides with the timing of puberty and growth spurt. Also, as you can see here, it is most common in males than females. So for the presenting symptoms, pain is the most common symptom, and 70% will present with pain as their only chief complaint. Onset of pain is often insidious, intermittent, involves the area affected by the tumor. It becomes continuous and more severe with time. And also, most patients will relate the onset of symptoms temporarily to trauma. But injury is not an etiologic factor in the development of your osteosarcoma per se, nor it is clearly tied to any particular event in the tumor's progression, with rare exception of a patient who presents with pathologic fractures. Most epidemiologic studies have not supported a relationship between trauma and osteosarcoma. Prior observation linking osteosarcoma and trauma were likely to result from the fact that a traumatic event may result in a pre-existing osteosarcoma being brought to medical attention. And the second most common symptom would be swelling around the affected bone. So tumors may be easily palpable, especially when they are located in areas such as the anterior surface of the femur, but may manifest only as leg edema when occurring in difficult to appreciate areas such as your popliteal fossa. Increase in swelling will affect the adjacent joint, leading to loss of function. So the third most common symptom would be a painful limp. So a painful limp that increases with weight bearing is the third most common symptom. Constitutional symptoms such as weight loss and fever are uncommon unless you have advanced disease. So given the nonspecific signs and symptoms, at the time of presentation, high index of suspicion is required of the primary care provider to avoid diagnostic delays and misguided treatment attempts. On physical examination, you may see a tender soft tissue mass with decreased range of motion. So in countries with limited resources such as the Philippines, late diagnosis and difficulties in accessing healthcare result in patients with high tumor burden, large tumors, and higher frequency of metastatic disease in excess of 40%. So laboratory evaluations often is unrevealing. You may have elevated LDH or elevated ALP, but these are more commonly seen in advanced disease. Also, ALP appears to correlate with osteoblastic activity and proved useful in monitoring response to therapy. Osteosarcoma most commonly involve the long bones, and most tumor occur around the knee. The most frequent site of involvement are the distal part of the femur, the proximal tibia, the proximal part of the humerus. Your axial skeleton, including the pelvis, is rarely affected. It typically occurs in the metaphysis of the bone, which is the site of new bone arising from the growth plate. So, radiologic evaluation must include assessment of the primary site as well as search for distant metastasis. Characteristic radiologic finding is your sunburst pattern, referring to a linear new bone growth that is perpendicular to the bony cortex, and it is arranged in a fan-like pattern. Other signs are your cumulus, cloud-like density, and the presence of a Codman triangle. Although plain radiograph are informative, it is but important to do your MRI and or your CT scan of the primary tumor. So which is which? Which do we choose? Studies would say that MRI and CT were equivalent in predicting bone, muscle, joint, and neurovascular involvement. However, your MRI is preferable for local staging, your pre-surgical planning, and your identification of your skip metastasis. This is particularly important in limb salvage procedures, but it is less relevant if amputation is planned. So a baseline radiograph should be obtained in search for distant metastasis, but your CT scan of the chest offers better documentation for pulmonary metastasis. And lastly, for distant mets, we should also do a bone scan. However, in resource-limited areas in the country, will skeletal survey benefit? Studies would show that you may miss around 35% of bone mets if skeletal survey is done. Okay, so once we have finished with all the imaging, we can now stage our patient to having a localized or metastatic disease. Although high index of suspicion for osteosarcoma can be exceedingly high based on radiograph alone, biopsy of the primary tumor for pathologic confirmation of the diagnosis is required. The most important adverse prognostic factor is the presence of your metastatic disease. Children with tumors of the tibia and distal femur have more favorable outcome than those with axial primary tumors. For those patients having localized disease, factors associated with poor prognosis include measure of tumor burden such as tumor size and levels of your LDH and your ALP. The percentage of tumor necrosis after preoperative chemotherapy is the most consistent and important factor associated with outcome. So if you have a tumor necrosis less than 90%, we have patients who are poor responders and have dismal prognosis. So the optimal management for your osteosarcoma consists of multi-agent chemotherapy and local control measures, including amputation or your limb surgical procedures. If surgery alone is done, result in 16%. Surgery alone will result in 16% survival. Radiation has no role in upfront treatment of your osteosarcoma. So of course, high-income countries have better survival rate as compared to your low to middle-income countries like the Philippines. So moving on to the next most common tumors in children, we have the Ewing sarcoma family of tumors, or your ESFT. The term Ewing sarcoma family of tumors would define a small group of round cell neoplasm of neuroectodermal in origin that manifest as a continuum of neurogenic differentiation. So when we have Ewing sarcoma of the bone, it represents the least differentiated or the most primitive, as compared to your PNET, which is the most differentiated form. So your ESFT represents 3% of all of pediatric malignancies, and in 25% of cases, they are already metastatic. So your Ewing sarcoma is the second most common bone tumors in children and young adults. The estimated incidence among white children younger than 15 years is 2.8 cases per 1 million. It manifests during the second decade of life with peak incidence in 10 to 15 years, median age of 13 years, and in 30% of cases in less than 10 and more than 20 years old. It is most common in males. It is most common in Caucasians than Blacks and Asians. It is now well accepted that Ewing sarcoma family of tumors constitute a single group of neurally derived neoplasm that share unique immunocytochemical, cytogenetic, and molecular markers. Nearly all cases of your Ewing sarcoma have a reciprocal translocation that involves your EWS gene in chromosome 22q12. The site of origin for this tumor are not restricted to your bone alone, as they may also arise in the soft tissue. So soft tissue in 15% of cases. And the primary site of disease, there is equal distribution between your eggshell and your extremities. And the most common sites are as follows: your long bones, your pelvis, your chest wall, or your ribs. The pain may be mild at first, but intensifies fairly rapidly. It may be aggravated by exercise, and it is often worse at night. So we may see a soft tissue mass that is firmly attached to the bone and moderate to markedly tender to palpation. Systemic manifestations such as fever are more common or more frequent than in cases of osteosarcoma. When you have back pain, extremity weakness, or altered sensation, it should raise suspicion of either a primary or a metastatic disease. So for the physical examination, you may see a tender palpable mass. And if you have centrally located tumors, the palpable mass may not be evident. Patients with suspected Ewing sarcoma should be thoroughly evaluated to define the extent of local disease and the presence of metastatic lesions. So your elevation of your ESR, your WBC, and your LDH is not uncommon. Plain radiographs typically show diaphyseal destructive lesion with laminated periosteal reaction and a large soft tissue mass. So biopsy is needed for definitive diagnosis, and if available, we can do our molecular pathology. Shown here is the appropriate staging investigations at diagnosis. And evaluation for metastatic spread should include CT of the chest, your bone marrow with biopsy, and your bone scan, because these tumors have the propensity to metastasize to the lungs, the bone, and the bone marrow. Metastatic disease, older age, large tumor size, trunk and pelvic primary sites are usually associated with worse outcome. And the most important prognostic factor remains the presence of metastatic disease up front. So for the treatment, we have a multidisciplinary approach, a risk-adapted chemotherapy, and for the local therapy, we can do surgery, or radiotherapy, or both. So in principle, if the tumor is resectable, surgery is the preferred method. Radiation therapy is used for cases of unresectable tumors or after surgery if the resection margins are positive. Despite the improvement of your treatment, the prognosis for patients with metastatic disease continues to be extremely poor, and only 20 to 25% survive. Okay, so this is my last slide. In summary, both tumors, your osteosarcoma or your Ewing sarcoma, may manifest as pain initially. We may see a soft tissue mass, and constitutional signs and symptoms are more present with or more frequent with Ewing sarcoma than osteosarcoma. The first diagnostic test to arouse suspicion for a primary bone tumor is a plain radiograph of the affected area. And a radiographic suspicion of bone malignancy should prompt quick referral to a cancer center for multidisciplinary care. So you should do imaging of the primary site, and as well as do metastatic workup. For your treatment, we can do chemotherapy, local control, and radiation therapy for Ewing sarcoma. Timely diagnosis is challenging for these both tumors because we may see patients that would come in late, and there would be non-specific symptoms that may mimic musculoskeletal injuries, and unfortunately we would have low suspicion by some physicians. So it is very important that if we detect these tumors early, then we have better chances of survival. So that's all. Thank you very much for listening.